Shall we start?
Yeah, no, just they will do the countdown.
They'll do the
That I will,
countdown.
after
Okay.
that I will start. Then I
Okay.
will introduce all of you.
Okay, sir. Okay.
Good evening, friends. After a brief hiatus, we are back again with the JICS Rapid Journal Review. And we know that once upon a time, thrombolysis or no thrombolysis following large vessel occlusion leading to stroke was a $1 million question, but that is no longer so. But definitely with the options of mechanical thrombectomy and thrombolysis both being available, whether a preceding thrombolysis is useful or not in patients having stroke after large volume obstruction is hotly debated subject. Since 2018, there has been 6 trials. And although the studies involved primarily the drug alteplase, there was reasonable enthusiasm over tenecteplase because of its better pharmacokinetic profile. Tonight, we are going to discuss the bridge tenecteplase trial, which was published in the NEJM, which compared mechanical thrombectomy alone versus tenecteplase followed by mechanical thrombectomy, that is for reperfusion in patients with large vessel occlusion. And will be presented by Surabhi Shamanto, who is a trainee DRNB critical care trainee at Escorts Faridabad, and he will be mentored by today's moderator, Dr. Amandeep Singh. We will also be joined by Dr. Arun Kaul. Dr. Arun, you are welcome. He is a professor of neurology at G.V. Pant Hospital in New Delhi. And we have our regular panelists, Dr. Pradeep Rangappa from Bangalore and Dr. Kapil Dev Soni from AIIMS, New Delhi. So without going further into other formalities, I invite Dr. Surabhi Samanta to present the study.
Good evening, sir. Good evening, everybody. I'll be sharing my screen and presentation. Sorry for the disturbance. Good evening, everyone. Today, my topic of presentation is intravenous tenecteplase before thrombectomy in stroke. My moderator being Dr. Amandeep Singh. We will be talking about the bridge TNK trial, which to see tenecteplase before thrombectomy in acute ischemic stroke. The study overview, the title being the efficacy and the safety of intravenous tenecteplase before endovascular thrombectomy for acute ischemic stroke, the multi-center randomized bridge TNK trial, which was published in May 2025 in NEJM. Okay, this is the original article. Background and rationale, we'll talk about it. Acute ischemic stroke due to large vessel occlusion is a leading cause of disability and mortality. Standard care is endovascular thrombectomy, often preceded by thrombolytic therapy, which is the bridging therapy. Alteplase has always been the standard. Tenecteplase is promising due to the genetically modified tissue plasminogen activator, bolus administration, single dose administration, longer half-life. It has a higher fibrin specificity. It can be infused rapidly and is less expensive than alteplase. Prior data were inconclusive. Bridge TNK aimed to address this gap. My study objective of this trial was to determine whether IV tenecteplase before endovascular thrombectomy improves functional outcomes compared to endovascular thrombectomy alone in patients with acute ischemic stroke due to large vessel occlusion. The study design, it was a multi-centered, open-label, randomized control trial. Location was over 39 hospitals in China. The duration period was from May 9, 2022 to September 8, 2024. Participants in this trial was 550 patients with acute ischemic stroke within 4.5 hours of onset, confirmed large vessel occlusion, among which 278 candidates were for tenecteplase plus thrombectomy group versus 272 thrombectomy alone group. Randomization was done in a 1:1 ratio to tenecteplase plus endovascular thrombectomy versus endovascular thrombectomy alone. The randomization was done by fixed block randomization with the block size of 4. Intervention was tenecteplase to 0.25 mg per kg as a single bolus before thrombectomy. Primary endpoint being the modified Rankin score of 0 to 2 at 90 days to see the functional independence of the patients. Secondary endpoints were successful reperfusion, excellent outcome of MRS of 0 to 2, and symptomatic intracranial hemorrhage and mortality. These were the inclusion criteria for the trial. Adult patient aged 18 years or older, presentation within 4.5 hours of last known well, acute ischemic stroke due to large vessel occlusion, typically internal carotid artery, M1, M2 segment of middle cerebral artery or the basilar artery. Patients eligible for intravenous thrombolysis, that is IV tenecteplase, pre-stroke functional status of a modified Rankin score of less than equal to 2 were included in this trial. Imaging criteria supportive of thrombectomy eligibility of aspect score more than 6 and provided informed consent, patients or legally authorized representative. These were the exclusion criteria for the trial. Any intracranial hemorrhage on baseline CT or MR scans as seen. Contraindications to intravenous thrombolytics. Any already received intravenous thrombolytic after indexed stroke. Known pregnancy or breastfeeding mothers. Contraindication to radiographic contrast agents. Current participation in another investigational drug clinical trial. Arterial tortuosity or other arterial disease that would lead to unstable access platform to prevent the thrombectomy device from reaching the target vessel. Patients with a pre-existing neurological or any psychiatric disease that would confound the outcome assessments. Patients with occlusion in 2 or more vascular territories, that is bilateral territories or anterior and posterior circulation. Any mass effect or intracranial neoplasm on baseline CT or MR, except on small meningioma. Patients were taken. Intracranial arteriovenous malformation or aneurysm or baseline CT or MR angiography, and any terminal disease with a life expectancy of less than half a year, patients were excluded from the trial. Primary outcome. The primary outcome was functional independence defined as a score of 0 to 2 on the modified Rankin score at 90 days. The modified Rankin scale is a 7-point ordinal scale of functional disability, score ranging from 0 to 6 with higher scores indicating more severe disability. This is a diagram depicting the modified Rankin score as seen in patients in tenecteplase plus thrombectomy group and the thrombectomy alone. The lightest color being with the no symptoms and a score of 0, and the highest being 6, and which indicates death. Secondary outcome. Successful reperfusion before and after thrombectomy as per the ETICI, that is the expanded treatment in cerebral infarction on angiography, was noted. Safety outcomes that were seen was symptomatic intracranial hemorrhage within 48 hours after randomization, death within 90 days, or any procedure-related complication and any serious adverse event. This is the diagram table that has been seen in the trial, which depicts the MRS score, the primary outcomes, and also the secondary outcomes. I'll be talking about the key results in my following slides. The key results that were seen in the trial was outcome of MRS score of 0 to 2 at 90 days in the tenecteplase plus thrombectomy group was 52.9%, and the thrombectomy alone group was 44.1%, with a relative risk of 1.20 of 95% of confidence interval and a p-value of 0.04. Reperfusion before thrombectomy was seen in 6.1% of the TNK plus thrombectomy group and 1.1% in the thrombectomy alone group. Reperfusion after thrombectomy was 91.4% in the TNK plus thrombectomy group and a 94.1% in the thrombectomy alone group. Symptomatic intracranial hemorrhage noted was 8.5% in the TNK plus thrombectomy and a 6.7% of thrombectomy alone group. Mortality at 90 days was 22.3% in the TNK plus thrombectomy group and a 19.9% in the thrombectomy alone group. The 8.8 absolute increase in the functional independence reflects a moderate but statistically significant benefit. Early reperfusion occurred more frequently in the tenecteplase group, though final reperfusion rates were equivalent in both the groups. Safety profiles were comparable with no significant rise in hemorrhage or mortality. There was subgroup and sensitivity analysis was done, which were basically across the key groups of age, sex, baseline, NIHS score, and the occlusion site. No significant interaction across subgroup was noted. This was the forest plot diagram that was provided in the trial, for which helps us to denote the subgroup and the sensitivity analysis. Okay. Then we come to the discussion and the interpretation of the trial. TNK before endovascular thrombectomy led to significantly better functional outcomes. This trial supports the bridging therapy approach even with a newer thrombolytic. No patients were lost to follow-up. No increase in major bleeding or mortality were noticed, which is an important safety signal from the trial. This trial suggests TNK is a better, stronger alternative to alteplase for pre-thrombectomy lysis. Clinical implications. What we can see from the trial is that may shift the practice towards routine tenecteplase bridging prior to endovascular thrombectomy. It could improve stroke outcomes in centers with delayed access to endovascular thrombectomy. And it also encourages further comparison between alteplase versus tenecteplase in large strokes. What were the limitations of the trial? It was an open label design. It was done on the Chinese population group, which affects the generalizability. Exclusion of the patients who needed inter-hospital transfer before thrombectomy limits the generalizability again. Role of tenecteplase in treatment of patients presenting more than 4.5 hours. Conclusion of the trial that we could draw is bridge TNK shows IV tenecteplase before thrombectomy is safe and more effective than thrombectomy alone. Adds to the growing body of evidence supporting TNK in acute stroke care. It may lead to changes in clinical guidelines for stroke management. This is a slide we have done a comparison to other trials. I'll be talking about Extend 1A TNK trial. It suggests higher reperfusion rates and the better functional outcome that we had seen with tenecteplase over alteplase before mechanical recanalization with large vessel occlusion. Then there was a trial in Swift Prime that was the patients receiving the IV TPA for acute ischemic stroke due to occlusions in the proximal anterior circulation, thrombectomy with a stent retriever within 6 hours onset improved functional outcome at 90 days. Another trial that was done was the direct MT trial in patients with acute ischemic stroke with large vessel occlusion. Endovascular thrombectomy alone was non-inferior to thrombectomy preceded by alteplase, administered within 4.5 hours after symptom onset. Another 2 trials published in Lancet with the Swift Direct and the Direct Safe trials was to address thrombectomy was not non-inferior to thrombolysis plus thrombectomy. In Direct Safe trial, they used 17% of patients for tenecteplase for thrombolysis as well. These studies do not support omitting thrombolysis before thrombectomy, as seen in the previous studies. Okay, these are the discussion points that I've put for further discussion, like should tenecteplase replace alteplase as the standard thrombolytic? Is bridging therapy superior in all cases or only selective patients? How can this data inform local protocols and the EMS workflows? That will be also.
Thank you. Thank you very much,
Thank you.
Surabhi. It was an excellent presentation. And now we open up the box for discussion. There will be a lot of questions and a lot of intrigues which needs to be settled and solved before we come out of the final conclusion. So I will start by asking Arun Kaul that Arun, when we look into such a study which wants to compare drugs or the effect of the drugs on the basis of a procedure, knowing fully well that a patient within 4.5 hours of onset of stroke is primarily a candidate for thrombolysis. Now, how ethical is it to design a study in a way that where we eliminate thrombolysis altogether in one arm? Means, had it been a thrombolysis plus mechanical thrombectomy versus thrombolysis alone, would have been a better way of looking into the problem? Arun.
Actually, sir, whenever we do thrombolysis, so it is mostly effective for small vessel disocclusion. We are here looking at a population which is large vessel occlusion, which by definition does not respond very well to thrombolysis alone. So it is the population that is going to benefit from thrombectomy, and it has been shown in multiple trials throughout. And by doing thrombectomy, we extend the time window which is available to the doctor as well as to the patient. Now the current guidelines suggest that we can do thrombectomy till 24 hours, and there are studies with tenecteplase also, which is that thrombolysis, even thrombolysis, there's a timeless trial that we can extend the thrombolysis period to up to 24 hours. So it is quite pertinent that we compare this thrombolysis alone and thrombolysis with thrombectomy. Earlier, most of the trials, as you already, the speaker also pointed out, that most of the trials were done with alteplase. In fact, it has been replaced by tenecteplase. That should not be a point of discussion. Mostly, it has been replaced. The most important thing being that it is given as a bolus dose, because we know that time is brain. Even
Absolutely.
1 minute delay is going to cause death for millions of neurons. So if you're going to give it as a bolus dose within 10 seconds, as compared to alteplase, where you have to wait for at least 1.5 hours. So tenecteplase should replace, I mean, alteplase. We need more trials. We agree with that. But the trial design is, I think, done sufficiently well, which answers the question that a bridging therapy is now the point of care.
Fine, fine, Arun. I go to the next important question that whenever when we subject the patient to thrombolysis, we also accept the risk of hemorrhage. Now, knowing that tenecteplase has a longer half-life, if we note that the spontaneous hemorrhage within 48 hours as a parameter for safety outcome, knowing fully well that a drug like tenecteplase can cause good amount of hemorrhage after 48 hours also, do you think that this parameter is correct, or it could have been better if you had chosen an extended timeline, say 96 hours instead of 48 or so forth? Arun, I will come to Kapil with that same question.
Okay. So I mean, it is a known fact that, I mean, symptomatic intracranial hemorrhage is the most important side effects, and we can have delayed hemorrhage as well. But the most important thing is that you should, whenever there's a hemorrhage, whether it is causing symptoms, which is defined in this trial also by the Heidelberg classification, sometimes there are only minor hemorrhages which do not affect the NIHS by, say, more than 4 points, or does not cause clinical deterioration. But greater timeline of assessment, it will definitely include more patients whom we deteriorate later on, and that you directly ascribe to tenecteplase and not the other conditions, because after the first week, as you're saying 96 hours, after the first week, the most common causes of deterioration are infections, UTI, pneumonia, and this, and we just need a CT to see whether the patient has bled or not. Most of the times these symptomatic hemorrhages are not, I mean, so this.
Sorry to obstruct you there, Arun. But don't you think that we can miss a good chunk of hemorrhagic transformation, which is even common in patients having such large volume occlusion or large infarcts following tenecteplase, if we make it 48 hours? Yeah.
But the important thing for hemorrhage is, if we are baseline, the inclusion criteria that we take. The speaker, I mean, they did not discuss the inclusion criteria. Here, the aspect score that was taken is more than 8. More than 8 is almost a clean CT, just 2 points lost on the aspect. 10 means that we have no evidence of any ischemia on the CT. 8 means it is relatively safe. More than 7 aspects, the first trial, the NINS trial, they had taken more than 7 aspects. If it is more than 7, the chance of bleeding is very less. And the second thing is NIHS. As the NIHS goes up, the risk of hemorrhage increases. And the large vessel occlusion, of course, the the present guideline says that in large vessel occlusion, if your aspect is even 0, 3, you can go ahead with thrombectomy. So here the baseline median aspects is 8. So it is less likely to bleed, but still the greater time window, we can include more patients. We can see the effect of delayed effects of, I mean, tenecteplase, whether the patient bled or not. But more important is whether it was symptomatic or not. Small amount of bleeding, it is very common, very, very common.
Okay, so we can negate that effect. Kapil, I'm coming to you on one of the technicalities of this study is the calculation of the sample size based on the incidence of functional of independence of 41%, and that was based on the previous three trials, the pooled analysis of the three trials. But if you looked at the trials actually did not have the same primary outcome. Now, when we try to pull studies with different primary outcomes, and from there we have to settle down to calculating the incidence for which we determine the sample size. How difficult it is, or uh, how the things work, Kapil?
So obviously they have to when you are
You can
designing a
turn on your
trial.
video, Kapil. It will make things easier.
Am I audible?
Yeah, you are audible, but you are not
Yeah.
visible.
So I'm a little bit outside, so I won't be
Okay,
able to.
right,
Okay.
right.
So so if you look at whenever a trialist designs a trial, they have to have some assumptions. They have to have some data with them to guess how much effect size they would actually appreciate, how much effect size they would anticipate in a if they do a perform a trial. So they went with almost 14%, right? 41% they looked at, and they thought that they
Right.
would have advantage of 14% if they use thrombolysis along with thrombectomy. This is reasonable based on the earlier data, because they had some pool data from the earlier studies, and based on that, obviously you argue that how much sample size, if you go for a large anticipation of efficacy or effectiveness, they may not be able to perform the trial, they may not be able to achieve the same sample size. So they have to have some reasonable assumption that how much effect they would anticipate if they combine the drugs. So I think they was fairly valued, and for 13-14% in a functional outcome seems quite reasonable. If that would have been a mortality, that that could have been difficult to establish in a mortality, but functionally 13% or 14% is a perfectly reasonable anticipation of effectiveness.
Okay, fair enough, fair enough. Amandeep, I'm coming to you. I'll go to Pradeep with the same question that looking at functional independence at 90 days by measuring a modified ranking scale between score of between 0 to 2 may sound quite authentic in a study, but how realistic or how practical it is? Do you think that we often do it, or do you do it in practice by with this kind of functional independence at 90 days, or do you think that this is a bit of theoretical exercise without much practical sense? You were muted, Amandeep. Can you unmute yourself, please?
Yeah, sir, right now. In our practical setup, if we see, it is very unreasonable to follow the patients at 90 days. And particularly coming to this study, it was all telephonic interviews which they did. There were certain video calls which they did. So that is in actual practice, it is quite lacking. For a study purpose, yeah, they were able to do it, and but in actual practice you don't do such, maybe because we are not seeing the patients in the outpatient department, but like Dr. Arun might be seeing there, so they are able to follow them at 90 days. So in from critical care perspective, we are not able to see such
So,
patients.
Pradeep, how would you like to follow them up for functional independence?
So, Anirban, so I was fairly intrigued with this study because when you look into the results of this study, I think the only significant quotient that they could identify is this functional independence, which I believe is little non-pertinent to core intensivists like us as Amandeep rightly said, we don't follow these patients to 90 days for the functional independence. But for me, why I say intriguing is, although if you look at the successful reperfusion before thrombectomy happened better with the tenectal plates and thrombectomy group, uh, before thrombectomy. So, which means to say, why then it did not lead to sort of a differential outcome with regards to, although successful reperfusion after thrombectomy actually was lesser in this group, 91 versus 94. So, did really thrombectomy make a huge difference in the reperfusion is a question that I would ponder about as to why that happened. So, before thrombectomy, you agree, okay, reperfusion happened in the first group. But after thrombectomy, you would have assumed that it should have been better in this group to correlate with the improved functional outcome. But that doesn't seem to have happened. So reperfusion was non-significantly different between these two groups. So why is it that hypothetically that we would assume?
Not really, Pradeep. The reperfusion was achieved in 6.1% of the patients following
That is
22
before.
days
That is
versus
before thrombectomy.
1.1%.
That is before
Exactly,
thrombectomy.
exactly,
Before
exactly.
thrombectomy, but after
Exactly.
thrombectomy. But
Acha,
after thrombectomy, it is 91.4% versus 94.1, Anirban. So, which means, what is your hypothesis that you do thrombectomy, that you would achieve a better reperfusion? That doesn't seem to have happened, isn't it? But then you are saying that functional independence has gotten better in this group,
So
Anirban.
that is a very pertinent thing that, Arun, when we look into two things, that reperfusion and functional independence, it is very easy, quite prudent to say that not always a good reperfusion or early reperfusion would lead to a better functional independence. And that is why probably the other studies which were performed before did not show much of a difference, significant difference between the functional independence between the two groups. So, to translate an early reperfusion into a good functional outcome, whether it is functional independence, whether it is mortality, whether it is anything else, there will be a lot of other factors, and those factors also need to be balanced between the two groups. We expect that balance in a randomized control trial because it is randomized, but not always it would be so. So how do you look into the functional independence, Arun, and in comparison to the other primary outcomes that people look for? And how would you rate reperfusion occurring before thrombectomy as a precursor to a better reperfusion after thrombectomy, as a predictor of better reperfusion after thrombectomy?
So coming to the first question, that how do we assess these patients? Actually, the problem with this MRS scale is that it is an ordinal scale. So a score of 2 and 3 exactly does not translate to a difference between 3 and 4 or 4 and 5. Like 6 means death. So a 1 point difference does not translate exactly to what we see. But unfortunately, we don't have many scales to assess this. So this is the scale that is most commonly used. Coming to the point of time when we use the scale, actually in stroke it is said that the small amount of improvements keeps on happening till 1 year. So usually whatever the stroke specialists do, they initially assess at 3 months, then 6 months, then 1 year, and it is taken that the amount of deficit that stays at 1 year is going to be lifelong. So that is point number one. Point number two is that thrombectomy, there are specific indications and there are some contraindications also. Like she had told that if the vessel anatomy is not very feasible, so the thrombectomy may not be very successful. And there is a particular criteria that the particular center should have this many of thrombectomy per year. The particular surgeon who is doing the thrombectomy should have this much of experience with thrombectomy. And coming to the reperfusion is basically based on a scale. Earlier it was like in myocardial infarction, we have the TIMI score, thrombolysis in myocardial infarction. Now they have modified this to the TICI score, thrombolysis in the treatment in cerebral infarction. So it has various grades. So based on this, whether it was completely reperfusion was done or not. So it starts right from 1 and 3, which means complete reperfusion. And it is well known that if you wait, that there will be some amount of patients even in large vessel, although thrombolysis is not advocated in large vessel occlusion. because the thrombectomy is the first line treatment, irrespective of whether they undergo thrombolysis or not. But it is seen that with thrombolysis, it is seen with altiplase also. If you wait fairly long, say you have given this thrombolysis, tenecteplase or altiplase at say 3 hours, when the patient came 3 hours within the egg test, then if you wait for 6 hours, 8 hours, 9 hours, and then do the thrombectomy, the percentage of patients who will have improvement in the reperfusion will increase. So it can be, so that is why the thrombectomy, whenever we do this, the scoring, the percentage of the people who have a reperfusion will depend on at what time the thrombectomy was done. And post thrombectomy, even if the score is not very good, the thrombolysis in the or the treatment in cerebral infarction is not very good, but the patient is improving, because as you rightly pointed out, that there may be various this factors apart from the perfusion which guide the prognosis of the patient, the recovery of the patients. And also the most important thing is the collateral circulation, because we are now coming to something called as a tissue based thrombolysis rather than the time based window. So many studies have already proven that. So point number one was that the MRS, we have unfortunately that scale, that's an ordinal scale. And regarding reperfusion, the greater time you wait for the percentage of reperfusion is going to be different, and it may not directly translate to the clinical benefit.
So that is fair enough. Your answer, you answered that even if the results of thrombolysis appear to be very good, if we delay the from the onset of thrombolysis to the thrombectomy, probably that is going to change the scenario, and that might be the reason in which case there were in this, as Pradeep pointed out, that although 6.1% as against 1.1% has better reperfusion was achieved following tenecteplase, the ultimately post thrombectomy, the comparison showed 94 versus 91, which was probably not that big. So that change, the duration between the two processes might have made the difference. Of course, the other factors would be there.
Dr. Anirban, I just want to add what Dr. Arun has spoken
Yeah.
about the ordinal scale. So it's not the first time that the ordinal scale has been used for outcome measurement. When you use any ordinal scale for outcome measurement, it poses a significant challenge, first of all, even to trialist, the statistician, and whatever the result they throw up for the interpretation. So an ordinal scale, you can always club people into a good outcome and a bad outcomes, which was the primary, if you look at this, which was the primary aim of this study. And they found out 8.8% of benefit, something like that. And that showed significant. But if you look at finer aspect, if you look at change in each point of MRS scale, they could not establish improvement in terms of, because the results were not significant. The generalized odd ratios, uh, which was used to know how much odds changes if we change the score from say 0 to 1, 1 to 2, 2 to 3, like that. It was not significant. Secondly, if you look at win-win ratio, now win-win ratios are the newer statistical techniques which have come up, and they try to give you a much more intuitive sense of outcomes, like how many wins were there and how many losses were there in terms of good outcomes and bad outcomes. Those were two things which were not significant, and the primary outcome, most importantly, was not backed up by improvement in the secondary outcomes, which were much sort of softer. So obviously there has been some benefit, but whether this benefit is consistent across all population or maybe in general practice, which I'm little uncertain about.
Amandeep, what are your thoughts on the same problem, reperfusion versus leading to functional independence, and the intrigues, the the speed breakers between the two?
The point is, if we go in this study, what the authors have discussed, they discuss about the trial which was done by Campbell et al. And was published in NEJM in the same journal, where they had used tenecteplase versus alteplase with mechanical thrombectomy. And in that study, as Dr. Arun had pointed out, they had increased the median time. In the present study, it was around 16 minutes. The median for the time was 16 minutes. And in that, It was somewhere between 34 minutes, more
No,
than that.
Arun has said that now we are moving from time-based strategies to tissue-based interventions.
Yeah,
So
but this study still discusses about the time-based thing. So that study was able to achieve a perfusion of around 22% reperfusion,
correct,
whereas as compared to the 6.1% which we had in this study.
correct.
So still, I think time plays a role. Uh,
No, time definitely plays a role. Time plays a role, but as far as the reperfusion is concerned, but in terms of the functional independence, which can be MRS at 90 days, the scale at or whatever, for probably for that time alone cannot be considered to be the decider. But Arun, I want to ask you one more question that finally, if you have to consider that when to consider or where in which subgroup of patients definitely bridging therapy needs to be considered. Of course, you have spoken about the aspect, you have spoken about the NIHS's baseline, and they have also looked upon those factors. They've got the pre-specified factors. What are the other clinical criteria that you would look for?
Actually, sir, now the decision is fairly clear. Whenever there's a patient of acute stroke who comes in the window period, whether or not he fits into this mechanical thrombectomy, you have to thrombolize. If it is within the window period for thrombolysis, and after that, if the patient qualifies for you, because you do a CT angio, sometimes the CT angio is not available right at the start. So we get a CT done, we rule out a hemorrhage, and based on that, we go for thrombolysis if the patient qualifies. And immediately, usually it should be done along with the CT. So CT angio is done. And if there's a documented large vessel occlusion, you go for mechanical thrombectomy if the patient is within 24 hours. So there is no confusion about that. And there are clear-cut guidelines about what the
No,
patient.
no. I'm saying that suppose the patient is also having a mild kidney derangement or some kind of diabetes uncontrolled, or with in the presence of comorbidities. Does that change the option
No,
of omitting the bridging therapy and going straight away for thrombectomy or looking into?
we should make it fairly clear that bridging therapy is just for large vessel occlusion, for which the standard treatment is thrombectomy.
Okay.
Because there are many centers where thrombectomy is not available. So there's a concept of drip and ship. That is, you give the drug that you have available, tenecteplase or alteplase, and then ship to a center where thrombectomy is done. So it is done in all the patient, irrespective of uh, whether the immediate mechanical thrombectomy can be done or not if the patient qualifies. So regarding diabetes is no contraindication, but there is a definite cutoff for the sugar that is more to rule out a stroke mimic, because if the patient comes with an acute hemiparesis, he might have a hypoglycemia. So there's a cutoff of less than 40 or more than 50. But now, whatever the stroke specialists say is that if you are even suspecting a stroke mimic and you're not very confident whether the patient has a stroke or not, you go for thrombolysis. The effect has been seen that the benefit far outweighs the risk, although there's a risk of bleed that is always there. Regarding CKD, even if he has a kidney derangement, no problem, it can be done. So there are specific guide of contraindications for thrombolysis. For thrombectomy, the most important factor is the operator's this skill. I don't remember exactly what is the cutoff in this they have taken. It is usually 50 to 80 thrombectomy should have been done in that particular center in 1 year or something like that. There's a cutoff for that. But clinically, any large vessel occlusion with a demonstrable deficit, go for thrombolysis plus thrombectomy.
So that brings out, coming to Pradeep, that is a very important and
Yeah.
that question
Yeah,
has
so,
narrated.
Anirban, 2 points that possibly
Bro,
uh,
let
make
me ask
mention.
you first the question
Yeah.
that since, as Arun has stated, that not all centers have facility for thrombectomy, and
Yeah.
this study has not considered inter-hospital transfer. They have also explained it in their limitation. So this
Yeah.
cannot be generalized. So what will you do to patients they are coming to you and you have thrombolized because you have 4.5 hours, it is there, and you have thrombolized? Will you refer them or you will treat them if you don't have thrombectomy facility?
So this is in relation to large vessel where there is
But
a
thrombectomy
option
has
of
a
thrombectomy. Yeah, I mean, that option will definitely have to be discussed because I work in a tertiary referral where we have all these facilities. I've not come across that situation,
Yeah,
but
you have. If someone doesn't have, then what?
yeah, they should be ideally, yeah, if it's a large vessel thrombus and functional outcome is something that is foreseen as being better, we should possibly facilitate transfer. And that is cited here as the limitation where those patients were not included in this particular trial. So I would consider Anirban. That would be my
So,
answer.
but then eventually they may not have functional independence. If you
No, no, I
consider
mean,
that.
not necessarily because the window period for thrombectomy is much longer. So I wouldn't exactly subscribe to that their functional outcome would not change with thrombectomy, especially when there is a room. So I think I would consider facilitating transfer to a place if
So I
it is
will
not
again
there.
go back to I will again go back to Arun, and I will come to Kapil with also the same question. So Arun, is it good to expect if the patient has large vessel occlusion patient has responded to positively to thrombolysis, is it good to continue treating the same patient at your hospital medically, even if you don't have thrombectomy facilities? Or is it better to refer the patient to a higher center where thrombectomy can be done, whatever may be the consequences later on?
Actually, sir, if the clot has been dissolved and you have facility for angio that has demonstrated a large vessel occlusion in the first place, then you have thrombolized and now the vessel is clear, you have achieved reperfusion, then there is no point of going for thrombectomy because there is no thrombus to be taken out. So if you have at least a CT angio or a DSA, which tells you that even after the thrombectomy, even after the thrombolysis, there is still the clot, the reperfusion has not been great, you please, I mean, transfer the patient for thrombectomy. It is a clear-cut guideline. I mean, there should be no confusion about that.
Kapil, I'm coming to you with with
Yeah.
regard to some of the secondary outcomes that we have.
Yes.
What they have said that they have not adjusted for those for those specific factors which needs adjustment,
Yes.
and that is why they have said in the last line that also the secondary should be tenuous because of this non-adjustment. Now, if this
Yeah. Yeah. So the thing is, they clearly state that they have not adjusted for multiplicity. When
yeah
you do a
multiple
multiplicity, yeah, when you do a multiplicity in the statistical analysis, the chance that any of the second outcome may become positive just because of a chance. If you do a multiple analysis and you don't adjust for multiplicity, so they didn't went for that because they had not planned accordingly, because the moment you plan it, you have to spend the alpha power for secondary outcomes as well. So largely in this trial, the secondary outcomes are more exploratory. But what I was interested in looking at whether the other functional outcomes like the MRS scores of 0 to 1, 1 to 2, the generalized odd ratio, or the EQ5DL, which is also a functional outcome, those are these lines with the primary outcome or not. Unfortunately, none of those were in line with the primary outcome, and that is basically a considered as a weakness, because it may be if the authors perform the same trial again, they may not get the similar results, and that becomes a little sort of a fragile trials.
So, but as Arun has pointed, it is quite well established that MRS at 90 days a score for functional independence is
Yeah.
a good enough. And
But MRS, as Dr. Arun has also spoken, MRS being an ordinal scale, it has got certain limitations. Ordinal scales are not like linear scales. The change in one unit does not amount the same amount of improvement subsequently. So there are always nitty-gritties interpretation of ordinal scales, and it's not easy to analyze and not intuitively easy to understand how much is improvement. So if you look at primary outcome, they have clubbed together good functional outcome and bad functional outcome, and they could show the benefit. But when they looked at subsequent change in the MRS scale, that benefit was not there.
so that's of course that's one. But another important thing aspect also wish to ask Arun is that now since there is always a tendency to go for extended the time. Now we have extended the one Surabhi had also shown the other studies where we tend to use the alteplase or tenecteplase beyond 4.5 hours. Now, is there any scope of thrombectomy also going beyond 24 hours, say to 48 hours or so?
Yes, sir. That is the concept of tissue-based window that I was telling you, because it has been seen that some patients who are thrombolized at 4.5 hours, they do, some patients do very well, but there are some patients, they, in spite of whatever you do, they don't improve. So it has been seen that if you have a particular this tissue at risk, and if you are able to demonstrate, say by a CT angio, that the collaterals are very good and there is a lot of tissue that is to be saved, so you can extend the time window. Even there was a timeless trial of TNK that has extended the thrombolysis to 24 hours. So uh, if there's a tissue to be salvaged, I think we can go beyond. I mean, although I'm not an interventionist, I never do this. We just refer the patients. The neurosurgery colleagues do this thrombectomy. But to my mind, if there's a tissue to be salvaged, the thrombectomy window can also be expanded, and I think we are gradually moving towards this tissue-based window, and the time window will gradually go off.
Aman,
I think Anirban, the
yeah.
timeless trial Arun was mentioning did show actually higher incidence of reperfusion when they extended the thrombolysis, but it did not lead to functional outcome. So, as he rightly said, I think the tissue salvageability or the amount of tissue that is salvaged determines more than reperfusion. I think that's possibly an answer for your previous question that we are pondering as to why functional outcome did not improve despite
Yeah.
successful reperfusion.
True, and we have seen that even in our hospitals, because in Safdarsjung it is mainly done by the intervention
Yeah.
radiology.
There are two more points, Anirban, which possibly we may not have addressed because someone was mentioning about the time factor. I think Amandeep or Arun. I think that was highlighted in this paper. There are two timelines that were identified because in the first group where they had an improved outcome, the functional outcome was better. They found that the procedure of the thrombectomy that they could do was 9 minutes lesser than the only thrombectomy group, which means the procedural aspects, the puncture to the reperfusion was 9 minutes shorter. And the authors do cite that possibly was the reason that functional outcome was better. So that is one aspect. And then they did compare with the previous trial because here the timeline from tenecteplase to thrombectomy was 16 minutes as compared to 43 minutes in the previous trial, and that had a bearing of 22% reperfusion versus 6%. So time does make a difference with regards to interventions as to how much functional outcome one. So time is something I think they have addressed in
Yeah,
the.
they have addressed, but if we go by the numbers, then we can say that the thrombectomy tenecteplase group had a higher mortality. Looking beyond those all those time, also they had 22% mortality as against 19%. Probably time has a role, but time doesn't explain everything. But among
Sir, one more question. One more question to Dr. Arun also. Uh, uh, in this trial, in the thrombectomy group, the investigators had given a leverage to use any kind of device for doing the intervention.
angioplasty stenting.
Whereas in the previous trials, like Swift Direct, they had one specified device being used for all the thrombectomy interventions. For Direct Safe trial, they had. So using the mixture of the devices does make a difference, or it doesn't make a difference. That is one thing which we are not aware of, and we don't come to know from this study also.
Sir, based on my knowledge about, because we frequently have combination, I mean, the combined rounds with the neurosurgery, they say that the first generation stents and all, they were not very good. At least because of that, there was many failures. And there are some, this neurosurgeon that prefer one particular type of a device. But unfortunately, we have only one or two devices that are available in the hospital. So they say if we have this device, I don't know the names of the devices, but they say that the device does make a difference. And if you reuse the same, because here we sometimes have to reuse one device. So if
Yes.
you use, the efficacy drops down drastically. So the device does make, although I'm not the right person to address the issue, but to me, the device does make a difference.
Okay.
Amandeep, I wanted to ask you one question because this is also we face. Many a times these procedures are done in the night, and after that patient is shifted in the ICU. and a CT is done the next morning just to see that everything is fine. And but patients don't improve. Say, so when do you think it is a clinic, it is a good time to address these issues to the patient, because who sometimes expect that patient will get up, improve, and the CT is also showing improvement, but the patient doesn't improve. So, what is the right time you think to actually to counsel these patients about the lesser chances of recovery despite having good CT?
Sir, it is a very gray area. There is no clear-cut timeline when to counsel the family just after the procedure. As you rightly said, maximum of these procedures are during the night time in the emergency hours, in the wee hours. And we have our one intervention neurologist with us who does these procedures. And I think still a 24 hours window period would be fine to give post-procedure update regarding the outcome. I think so. But still, I would like to have an opinion from Dr. Arun on this, when they would like to do the counseling. Because in my opinion, it will be a 24 hours window before we commit to anything.
Yeah, so that is a gray area, Pradeep. I don't know what happens to you, but many a times the intervention radiologist, sir, if the once he sees the CT is normal, he says, sir, you can go ahead and extubate the patient. But how can you extubate when the patient is not improving clinically? So this is a frequent situation, and it falls upon the intensivists to actually counsel the patients about the recovery, and also to tell them that the chances are less. Now that becomes sometimes. So, is there any optimum time period? Well, Arun, is there any optimum time period we can expect that this patient is not going to recover?
Sir, actually, with thrombolysis, the guideline is very clear that whenever you do a thrombolysis, if the patient is the same or it is improving, you don't, immediately tell whatever, and you don't go for a reimaging. The protocol says that after 24 hours, you do a reimaging and see. The most important thing that we need to see is that on the image whether the stroke has evolved or not. You will be easily able to assess on a plain CT scan when the patient has come to you at say 4 hours, and then you do another CT at 24 hours. If the patient has a successful thrombolysis, the stroke is not going to evolve. There are other methods also, perfusion and diffusion. You can see whether there is the penumbra that was there, it is has been saved. And if that is not matching with your this clinical, then you look for some other causes. The most important thing to look for is whether there has been any deterioration, and that could be because of raised ICT, that could be because of bleeding, that could be because of procedure related complication, a thromboembolism, or anything XYZ. But if there is a reperfusion, proper reperfusion, tissue has been salvaged, as Dr. Amandeep has rightly pointed out, that immediately after that the patient is going to show improvement on NIHS. The As I first pointed out, that the patients of stroke take some time to improve, and it is said that we should not, give up on them till at least 1 hour before, 1 year before you tell them, okay, now you have a fixed deficit, this is not going to improve. Because apart from treatment, it has been seen that good physiotherapy, occupational therapy is going to improve the outcome, but that is not going to drastically change the NIHS. NIHS will change based on a successful reperfusion and the tissue being salvaged. So, right time to counsel the patient that the patient is not going to improve, you see the clinical and you see a CT. If the stroke has evolved, it is unlikely. If there's an infarct has been.
So the short-term prognostication would be at least 24 hours then post-procedure,
Yes.
or post-thrombolysis, I think.
Yeah, usually the guideline says that after 24 hours you do a CT and see.
24 hours.
Yeah, yes.
And we have very little time left. We are going before the last question. Which will be common to everyone. I will ask Kapil. One interesting thing I have noted in this study as that no imputation of missing data were necessary, because all the patients, all the data were available to them, and this is quite surprising in a current setup, because most of we don't rarely come across studies. And if it is a study from China and saying that no imputation was required, then probably it increases. Or what do you think?
Yeah. So, means I must. It's very. So this being a field study, probably they were doing telephonic interviews, as they already mentioned in in the details of discussion, and they also were doing the videographic interviews. And the strength of the study is that there were no loss to follow up. And though this seems to be quite amazing to us, because we in a critical care we are used to have a lot of missing data, primarily because of loss to follow up. However, I'm not sure about how they went on and they could actually approach each patient, but definitely their setup actually allowed probably, and that's why they did not require to have a imputation for missing data. So they had a very good follow-up. Loss to follow-up was quite negligible here.
So thank you. So Kapil, now I'm coming to the last question. Of course, I will start with Amandeep and I will end with Arun. And the last question will be same for everyone. What are the two important messages that we can grasp from this study according to you? I start with Amandeep.
Sir, I think tenecteplase and the thrombectomy arm has shown that this is a now important strategy for large vessel occlusions. So we should consider it. And I think if we don't have a facility for mechanical thrombectomy, then we should be using tenecteplase for thrombolysis and
Upfront.
we should shift the patient to a facility, or we should give the option to the family for option of mechanical thrombectomy. And if we can shift the patient ASAP, that it will definitely help in improving the outcome. Though this is only the single study which is showing some improvement in the functional thing.
No, there is
Still,
one more study. One more study has been published this year from the
so I think more studies are still required to show a robust data, which we should have to emphatically say that it definitely is doing something in improving the functional outcome.
Okay. Pradeep, two important messages from this study.
Yeah, so the important message, the science remains pretty clear now that if it's a large vessel thrombus, you try to move towards thrombectomy. And thrombolysis is whether you would combine this with the thrombolysis for all the patients within a strict timeline of 4.5 hours. So although this study looks little compelling in that sense, but there is no other difference in any of the outcomes. So I would wait for more data. And this is from China, so I would possibly have little skepticism whether I would consider this as a standard of care at this point of time.
Kapil, your thoughts?
So yeah. So obviously, based on one study, the guidelines will not be changed drastically. But definitely, what this study showed that there wasn't too much of safety outcomes which were bothersome. There was some increase in symptomatic, hemorrhage, but that was not significant. So you can safely give, based on risk and benefit analysis, you can safely add thrombolysis to a thrombectomy strategy, and that can have some improvement. So I think relatively safer. It's not that it's very unsafe study. Unsafe intervention.
It is not a risky. It is not a risk.
Yeah. So if you look at, you can still combine both, and you may have some hope that there would be some benefit. Though if you look at number needed to treat would be at least 12 to 13 patients. So that you need to treat to identify one more advantage.
Yeah. Just to add one point to Kapil, which possibly was not discussed, I think the effect size actually fell short in this as per the authors themselves. That the expected effect size was 13%.
Yeah, so they got around 8.8%.
Yeah, so
that was
slightly another limitation.
Yes, sir. Lastly, Arun, two important messages that can be grasped from this study.
One would be, sir, use tenecteplase as much as you can instead of LT-place, because it can be given just as a bolus dose. And second,
in large vessel occlusion or in all occlusion?
Any thrombolysis.
In any thrombolysis.
In fact, it is available in GB Pant. We have for the last 1 year, we are mostly using tenecteplase. Most of the people are now using tenecteplase. And second, of course, as the other panelists have mentioned, that large vessel occlusion, go for thrombectomy plus thrombolysis.
So, friends, the message is very clear that in cases of large vessel occlusion where mechanical thrombectomy, the timeline is 24 hours, needs to be looked for and best, but don't miss out on tenecteplase, because probably it is worth taking that risk for improvement in the perfusion. How much translates into functional independence may not be great, but in terms of perfusion, definitely that is likely to help at the least possible risk. I thank once again to all our eminent panelists for taking part in this discussion. And friends, we will be back again on the second and fourth Thursdays of every month with some interesting article again for discussion. For till then, we are back from all of us from Jake's Rapid Journal Review. Shubhratri, Shabr Khayat, and good night, and have a happy Rath Yatra. Thank you very much.
Thank you, everyone. Thanks,
Thank you,
Ravi. Thanks,
everyone.
Arun. Thanks, Amandeep. Thanks, Anirban. And of course, Kapil. Nice inputs on statistics. Thank you. Thank you, one and all.
Thank you, sir.